Hello and welcome to the Abbvie Symposium, where we will discuss the use of Venetoclax and how Venetoclax is changing the standard of care for AML unfit patients who are not fit to receive traditional chemotherapy. I'm Dr. Maria Marta Rivas. I'm from Argentina. I'm a hematologist from the Hospital Universitario Austral. I graduated from Universidad de Buenos Aires. I had my title granted by the Argentinian Society of Hematology. I'm a teacher on hematology and a member of the subcommission of acute leukemia of the Argentinian Society of Hematology. This is our agenda for today. We will discuss different issues as to how Venetoclax has changed the treatment of unfit patients. In a first presentation, Dr. Gómez will discuss the combinations of Venetoclax to treat acute myelodysplastic leukemia. And he has published 33 articles in international magazines and journals. He has received the grant of Global Research Award of American Society of Hematology, and he is part of the working group of acute leukemias in Mexico and different executive committees in Latin America, the US, and Europe. So with you, in the northeast of the country, in the border with the US. And thank you very much for the
Gracias.
invitation.
Thank you very much, and Abbvie, who are the sponsors of this symposium. And I am here to talk to you about this molecule that has become in the new standard for AML for patients who are considered are not candidates to receive intensive treatment. Here in this slide, you find my contact information. I'm at your service. This is my disclosure. You can see in the slide. And I'm going to give you a brief introduction of the two pivotal studies where we compare with placebo in AML. We've seen that this condition has an incidence that increases with age and the survival decreases. And this is seen with the functional capacity of the patients and a more aggressive biology of this disease that's resistant to treatment with aging. However, in some Latin American countries, in particular in Mexico, such as Brazil, the median age is more than 1 decade, less than what's been reported in high-income countries. And most of patients are going to be candidate to intensive therapy, which is something that's worth mentioning. Here we see the alternative approved by the FDA. Support therapy is no longer considered appropriate treatment for patients with myeloblastic leukemia, followed by low-dose cytarabine, and then combinations, which are the two treatments that were previously available.
Now there's venetoclax, azacitidine, cytarabine, and ivosidenib and glazagiv, a Hedgehog inhibitor. And in second line is enacitinib, gilteritinib, FBT3 inhibitor. These are the lines which have been approved, but we have to remember that only these four have been tested in a phase 3 randomized trial. The first two in first line with positive outcomes. The N-acetylene, though it has not been published, there has been a press release and a presentation in EHA where the result compared to AZA was negative first line. And the gilteritinib, which has an advantage in survival for second line compared to chemotherapy when it was tested against AZA, and our outcomes were negative, which have not been published, like the inacitinib. So these are the two therapies which have proven improvement over placebo first line in combination with HMA. And these are the two big differences of pivotal studies. VLSC included patients who received HMA, and also there's a difference in the Venetoclax dosing, which was 400 against 600, and you can see here the comparison between placebo and cytarabine or AZA. And here in this slide, I would like to mention two eligibility criteria where you can see the information for the clinical practice, meaning that these are patients over 75 years of age with a close criterion and 18 to 74 with one of these comorbidities, heart failure, angina, ECOG 2 or 3, and these two findings in the respiratory test in the VLA. Some patients were excluded and not so in the VLSC. And the primary outcome was the overall survival. In general, in this study, it's quite representative because there were patients with all different characteristics. Most of them were over 75 years of age. One-fourth had a secondary AML, either myelodysplasia, myeloproliferative treatment, and there were patients with poor prognostic molecular data, which is important to mention. In general, the outcomes were quite outstanding and increase more than double in complete response. The combined outcome and endpoint, which separates from these arms with an important magnitude of this event and a very good overall survival. So there are no doubts now that this is a very good treatment for people with AML, which is superior to AZA. It is not perfect. Venetoclax can cause neutropenia, fever, more than with placebo, and risk of severe infections and mortality associated to treatment, which fortunately are low numbers and known for lymphoblastic leukemia. So we are now learning how to use this molecule. We still have a lot to learn, and there are many patients in this study who had an interruption or discontinuation due to the dose reduction. In general, in subgroup analysis, there was a benefit found for most. I would like to highlight that patients who have other molecular alterations, such as the IDH mutations, were also benefiting from this therapy because oftentimes, if you have a molecule which inhibits or affects certain mutation, automatically I would like to use it. However, this is not necessarily true. And this is regarding IDH inhibitors versus Venetoclax, which is still a very good therapy. There are some details that Dr. Rivas will discuss later on. Leaving patients to recover, the use of colony-stimulating factors, I won't dwell here, and some adjustments that need to be added together with other drugs. Now, speaking about the VLSC study, which had a lower sample size, the Venetoclax dose here was greater, 600 milligrams, with the endpoint, which was the overall survival, like the other case, though the expected magnitude was higher, though there were more overall responses compared to placebo. The difference in the primary survival analysis did not have a significant advantage. However, in the update 6 months after, then the significant advantage was thus observed, and this is a statistical detail which has a minor importance. In Mexico, we have used this drug. It was approved, like in the US, before the publication of the VIALE A and C studies. So we were concerned to find out if this was to be better or not. We started to document this in our patients with the acute MDSs. We included some patients from Peru as well, and we see that the outcome is good. In the first chart, you see first-line treatment, and in the second one, these are the relapses. Though it has not been approved in the US for this indication, and we would be very pleased to add any one of you. We will update this cohort of patients to know how they are doing in our reality. So with this, I would like to conclude. What these two pivotal studies have proven is that venetoclax in combination with azacitidine is superior to azacitidine alone, and likewise venetoclax in combination with cytarabine is superior to cytarabine plus placebo. However, it is important to remember that these studies are not comparing the use of venetoclax against intensive therapy, which automatically, when you have a patient over 55, 60, or 65 years of age who could receive intensive therapy, you want to save them this deterioration associated to chemotherapy. However, there's no sufficient evidence to give this recommendation. In the future, I'm sure we will discuss this issue even more, but today we cannot say that this is a substitute to intensive therapy. Indeed, there's evidence that this is a new standard in treatment. The real-world studies, though they are not equal or matching, they have also shown similar responses, and in our country we have proven this, and there are more combinations in the way they want to use venetoclax everywhere, in the water, in Coca-Cola, because it's a molecule that has been very positive in different scenarios, but we have to learn more as to how to use this combination better. And with this, I would like to give the floor to Dr. Rivas, who will give her recommendations as to what to do, what not to do, and how to better use this drug. So once again, this is my contact info. We are active in Twitter for those of you who follow this network. Thank you. Thank you very much. And everything that you have said, it's very interesting. I would like to remind you that below the screen, below the slides, you have the possibility of asking questions that will be discussed. We will have a space for Q&A after the three presentations. So now, with my presentation, we'll move on. In these 10 minutes, I will try to discuss how to monitor patients on venetoclax and how is the management of these patients using the same drug. These are my disclaimers. And by way of introduction, I would like to show this work published by Dr. Poria some years back, where he shows, and this is something that is frank reality, that patients treated in real life do not have the same results of those who are included in clinical trials. Apart from the selection that might be performed of the two populations or different populations, what we know is that not always physicians are so stringent and so adherent to protocols in real life. Well, no doubt this is not easy, and with new drugs, well, no doubt there is a learning curve that we have to live with. It takes time to get to the best management with each one of these combinations. And this is not something we are alone at. This has happened to many, and we've had a numberless publications where 3 years ago they are explaining us that we have to manage these patients under these new drug combinations and how we need to handle their toxicities, their interactions with other drugs. And regarding venetoclax with azacitidine and low doses of cytarabine, the recommendations are focused, and this is the topic of my presentation, the management of cytopenias. We don't need to fear cytopenia per se, but we have to take charge when this has clinical implications, when they have an infection associated to these cytopenias. Some things to bear in mind when we start treatment and we believe or think about the management and the combination of drugs, we need to try to use both drugs at the same time. We know that especially HMAs, but also low doses of cytarabine will foster the effect of Venetoclax. So this is interesting to start both of them at the same time. Another thing to argue, which might be revised in the Q&A session, we know that most of the patients will stay hospitalized, maybe through the first cycle, and as we start learning and using this combination, we will leave certain fears behind and maybe we dare have them as outpatients. Today, with COVID times, you know that the bed at a hospital is essential. So maybe we could treat them at hospital, but also at their homes, especially during the uh, periods where they actually don't require hospitalization necessarily. When we face treatment and we know Venetoclax with chronic fatigue, we have to be paying attention to the tumor lysis syndrome. This is much easier. The incidence is much lower. So this is why the introduction of Venetoclax is shortened. We know that we need to ramp up somehow, and before the ideal thing will be to accommodate the patient, try to reduce the white cell blood count to less than 20,000 per 10 to the ninth, and we have to hydrate them, and of course the whole chemistry has to be evaluated to see where we stand, what kind of tumor lysis per se is occurring, and what's the risk that this all entails. From the beginning of Natoclax, it's 100. There's a very fast ramp up. Afterwards, when it's combined with hypomethylating agents, it's 3 days, and then we start with 100, day 1, 200, day 2, 400, day 3. 4 days only when it's combined with the low doses of cytarabine, and 100, 200, 400, and 600 combined with cytarabine. During the whole treatment cycle, we know that we will have cytopenias, that those patients will certainly require transfusions. We have to, we are inducing a patient with an LMA, so we will have AML, so we will have to deal with cytopenias, eventual infections with transfusional requirements. The recommendations are to be able to maintain them through this 28-day induction. In some instances, this might be shortened, and try to assess day 28 what's the response to treatment. If there's disease persistence, we have to continue, we have to start a second cycle. But, however, if we can control the disease by presenting less than 5% blasts in the bone marrow, we can then put off the beginning of the next cycle to give them the chance to recover. The recommendation is that the patient is able to have more than 500 neutrophils and more than 50,000 platelets. and the colony stimulating factors is then enabled so that the recovery will be sooner with these patients. Even more so, this is a publication from ASH, educational edition, where Dr. Wang shares that we can even try to evaluate at day 21, apart from day 28, to shorten cytopenias, because by day 21 we can already have response to treatment. In the VIALE-A, over 40% of patients who responded had this response in this first month of treatment. So in view of a patient where he's complicated because of the cytopenia, maybe we can anticipate the bone marrow aspirate to day 21. And you need to know that even in VIALE-A, there has been a postponement, and there's even recommendations to leave like a resting period, even though some of them might have full remission and have long cytopenias. Try to find a way to reduce the duration of the Venetoclax dosing to 21 days, or even postpone the beginning of the next cycle to let them rest, to let them recover from their cytopenia, and so that they won't have so prolonged neutropenias. From those patients who responded to VIALE-A, 69% of them reduced their dose to 21 days throughout the whole follow-up. Unlike patients who got placebo, 30% of them had to reduce the dosing. So to conclude, the recommendations is to shorten the duration of Venetoclax once they get to full remission. If this recovery takes more than 14 days, we can reduce in the next cycle the Venetoclax days, going from 28 to 21, from 21 even to 14 days. Another point to consider is reducing the intensity of the HMA dosing from 50% or 30 or 40%, especially when they're hypocellular or when the cellularity goes from 50 to 30%. And considering the G-CSF prophylaxis, and starting filgrastim day 8, where they are using HMA, or day 11, when low doses of cytarabine is being used. And last, in managing Venetoclax, we cannot fail to mention the cytochrome P3A, well, the azoles, which are, or azolic, which are stronger inhibitors of the CYP3A. We know that in VIALE-A, a small percentage of patients has used as azolic as prophylaxis, and there's no impact in the response rates apart from using these drugs. So what happens with these inhibitors? They promote the effect of Venetoclax. These are pharmacokinetic studies which associate the use of posaconazole with Venetoclax, where we know that this is multiplied by 3 and 4. I mean, the Venetoclax levels in the blood. So the recommendations is that we should reduce the Venetoclax dose to 75%. So if we combine Venetoclax with strong inhibitors as posaconazole, voriconazole, we have to reduce the dose to 100 or 70 milligrams of Venetoclax. In general, in practice, we use 100 milligrams, since it comes within the same package when we ask for the drug. But if we combine this to some moderate inhibitor, as is abunoconazole, we have to cut it half, 200, when we combine with azoles and hypomethylating and 300 when they are low doses of cytarabine. This is everything. Just concluding that we are in view of new treatments on acute myeloblastic leukemia, and we need to learn more about this. Thank you very much, and I will be here for the Q&A session after Dr. Nicolas' talk. So I will introduce Dr. Cazap. He's a hematologist from Argentina. He's part of the CEMIC staff and the Clínica Olivos, also hematologist at this clinic, and he's a member of the subcommission of acute leukemias of the SAH. Nicolas, the floor is yours. Good morning. I would like to thank Abbvie the possibility of taking part in this interesting symposium. I will speak about the practical, real-life management of AML Unfit patients treated with Venetoclax complications, and maybe see how all of these recommendations have been articulated in real-life cases. I have to clarify that this does not represent the reality in all Latin America, because the situation varies, and it does not even represent the reality of Argentina, let alone my city, Buenos Aires, because you might have different possibilities in different places where the infrastructure is different, which might facilitate one alternative or the other. These are my disclaimers. So let's discuss two clinical cases of real life pointing to the treatment election, the inpatient versus outpatient management, and then the practical management for antifungical and real case cytopenias. The first case is a 73-year-old man with a history of hypertension and COPD, hemorrhoids, treated with amlodipine. In November 2019, he had fever and rectal bleeding. He had severe anemia, hyperleukocytosis with blast predominance, and there's AML with a genetic profile that places him in intermediate risk. He did not have disseminated intraocular dissemination, and he started treatment with Venetoclax and AZA as an inpatient. In Argentina, we use national guides that we have widely developed, and as we see here in the algorithm, this is for unfit patients. The combination of Venetoclax with HMA or low doses is the drugs of choice. This is a pivotal study where the overall survival rate improved, and I mentioned that we have the NCCN guidelines of the US as something to consider. We have to remember that Venetoclax is taken with food or with a glass of water. Voriconazole was administered with Venetoclax. The dose reduction was 100 mg per day during neutropenia, and then during the fungal infection diagnosis. There was suspicious of this fungal infection, so the prophylaxis was good. Anyway, this is something controversial. In the initial studies, the infectious rate is grade 3 and 4, 8% in this case. In these initial studies, which are not VLA or VLAC, azoles were prohibited, but they had echinocandin. Then there were interactions about the azoles and Venetoclax. Dr. Rivas showed how the dose reduction has to go about. Regarding the efficacy, there are similar rates of full remission. And likewise, echinocandins can be administered because they are hospitalized. There are recommendations where not everyone advises to use them during the ramp-up period. For practical purposes, most of the institutions use institutional guidelines of infectology And as you see in our guidelines, in AML and induction, the prophylaxis, antifungal prophylaxis is indicating. So how's the evolution? At day 28, there were cytopenias, and the management was with a cycle delay and the administration of stimulating factors. There's a practical issue here on the day of biopsy, day 28. Sometimes we don't have the result the same day. Sometimes the aspirate is not representative. So there's a situation where we frequently have to wait. There's a delay of the next cycle apart from the response. The patient is alive and in complete remission after 17 cycles of venetoclax, azacitidine, and the suspension and delays are 0 to 7 days with variable use of filgrastim, without use of filgrastim as well, and there was just one infection in cycle 2, and then he never presented the situation again. Now let's move on to the second case, 70-year-old man, dyslipidemia, rhinitis, varicocele hemorrhoids. In 2018, he had a tricytopenia, moderate to severe tricytopenia, and there's an intermediate risk MDS diagnosed according to different classifications or high risk, but he starts treatment with ISA alone. The response was correct, and throughout 2019, he had moderate cytopenias during treatment-free periods. In 2020, there is a worsening and severe pancytopenia, and there is AML diagnosed. He did not have DICs, no TLS, no bleeding, no fever, and he had leukopenia and a good general condition. The decision was to start venetoclax LDAC as an outpatient in this case. So regarding this, most of the recommendations, as has been mentioned, this treatment was with hospitalization first, 72 hours of hydration, and now most of the places this should be with hospitalization, but now we are considering the outpatient treatment of these patients, and there are publications of the last ASH Congress where the possibility of having outpatient treatment, especially TLS, that was 2.5% in patients, and this patient was hospitalized. Measures were used, and he did not develop clinical TLS. So in local experience, and let alone during a pandemic, I consider that the treatment as an outpatient, if the characteristics are present, is quite due. So he started these patients, he started with this treatment, Venetoclax LDAC, as Dr. Gómez mentioned at the beginning. There were patients included with MDS, but they have received HMA before. So these are the general results of this study with a better overall survival. With HMAs administered before, with venetoclax and ASA, off-trial patients, as in this work, the responses were somehow lower but superior to those that are known for HMA treatments. The antifungal prophylaxis with posaconazole, this is another example of how you can vary the drug of choice with a venetoclax dose reduction to 100. And there was very short admission at day 15 because of a febrile neutropenia that was resolved soon. And after cycle 1, he got to CR. He was still neutropenic, resolved with suspension of venetoclax and holding the G-CSF. 2 weeks after, he continued with treatment. Then, in the cycles of cytopenias, it was variable reduction from 0 to 21 days. And in this case, they did not use a dose reduction of any of the agents, and there was some delays in some CSFs. He was ambulatory without complications in the following 6 months, and 2 weeks ago, unfortunately, he had a relapse with a febrile neutropenia and a septic shock that killed him. So this is a very short personal experience of a center where I work at, and these are the characteristics of the patients that we work with.
Schemes that were used in antifungal prophylaxis, we see a diverse indication. We see that we use the treatment in outpatients has been successful, and the outcomes are quite diverse, but with good results in some of the patients. As take-home messages, the Venetoclax combinations for the treatment of AML are effective and manageable, even in the outpatient situation. The antifungal prophylaxis is controversial. Dose reductions and echinocandins are to be considered. Cytopenias are managed by cycle delay, dose reduction, and the use of stimulating factors. Thank you very much. You very interesting cases. Now we're going to start the Q&A. No, we're going to start with what the ones we have. How do you define an unfit patient in the clinical practice? Do you use any specific scale? Who will start? Yes, I will start if that's okay with you. This is a good definition. The first test that you do is the eyeball test with the clinical impression that you have that if the patient can receive intensive treatment, but you need to be more objective. There are several scales. PRN model from Seattle has been approved. Ferrara criteria are also had good external validation and are equivalent to the Seattle score. These are the ones that were used in the Viales studies. The ECOG, cardiac failure, respiratory function tests, all of these are fitness criteria. And this is what I use in my clinical practice. In our clinical practice, in general, we don't use the recommended scores for comorbidity risks. We have heard about them in presentations, but in the clinical practice, as Dr. mentioned, just the clinical eyeball that we see as a patient in the office. Perhaps in the patient who's 65 to 75 years of age, where there's some doubt for transplantation, we apply the transplantation score, just for that reason. Great. Yes, the patient between 65 and 75 is a big challenge. And the fact that the patient has an ECOG impaired by the disease, and perhaps tomorrow, if there's a response or change in the patient, then perhaps it will make us think ahead in transplantation as an alternative. Any additional comment on this regard? I think that this is the most important major success of Venetoclax. It saved life of people in which chemotherapy perhaps would have not done it. And this is a clinical experience, but on diagnosis, the patient is not a candidate for intensive therapy, but 1 or 2 months later recovers what he or she lost, and there's the option of curative therapy. I have experience, personal experience in this regard, and they're very happy, and they continue treatment and control. Wonderful. There's another question. In patients with TP53 mutation, the combination of Ven-Asa in LA show good rates of CR, but not impact on survival. Do you consider that it's worth using Venetoclax because of its cost in an elderly patient in this scenario? if you want my view, perhaps in these kind of patients, following the previous questions, these are obviously patients that for the time being, although there are new drugs under study, the only alternative for therapy is transplantation. But perhaps these are patients that might achieve a good induction and remission with the use of hypomethylating agents and venetoclax, and then going to transplantation. Perhaps that road. If not, of course, this is under intense discussion, the use of this combination with this cost, knowing that we're not being able to sustain it in time. I think that at the end of the day, it depends on an informed decision with the family. We know that in studies, the quality of life is better, like they reported in the last ASH of a combined study of VLA-A and VLA-C. Although the studies were not designed to test patients with P53, although it is difficult that this can cure them, but it will improve their quality of life. And if that case, the family decides that they can afford the cost, this will be an informed decision. Great. Okay. Another question. What is the use of Venetoclax AZT with patients with AML secondary to myeloproliferative sensors? Well, you saw that in my experience, we've used in patients with LMA. What we've seen, well, these patients were not included in the initial studies, but there are some data. There's a recently published study of 32 patients in the American Journal of Hematology, where the remission rate was better than the historical in this comparative study of 44% versus 4% with hypomethylating agents. My understanding is that patients respond less and do worse than those who have a myeloproliferative disorder. But in non-comparative studies seems to be better the current, the regular treatment. For patients should also be receive some other therapies. We have another question. Given that venetoclax should be more effective in patients with IDH and NPM1 mutations, do you think it's worth to know about the mutational status to predict who are going to have more response, or for selection of patients who will benefit more from this drug in case of having a cost issue? In the patients in which you have no doubt that they're going to go to non-intensive therapy, of course, we do the prognostic studies, but I understand that this has clinical relevance. Perhaps in the patient where you have some doubts if it's going to go to non-intensive therapy or intensive therapy, followed by transplantation, I think it is important to consider the patient has a good prognosis because they would incline towards a curative therapy. Dr. Gómez, I fully agree. I look for patients who have favorable risk alterations can also modify the decision of indicating therapy in intensive therapy, because we know that this patient can be cured with high doses. In this group of patients between 65 and 75, we can consider this study. And that question is very relevant because if there's cost efficacy from specific mutational group, it's worth studying. And it's a question difficult to understand because the context is different in each country, the economic resources. I work in the public and private sector, and decisions are made different according to the scenario. But I think it's a very good idea. I know that in the future, we're going to, if we can have the entire mutational panel, we will be able to select drugs and for each type of mutation. But for the time being, In the unfit patient, we don't have an alternative because Venetoclax combined with ASA in low doses could be the option. So it will help us in those patients in which we have some doubt. We have other questions. The patient with Venetoclax ASA plus azole, like fluconazole, in induction after reaching complete response for the following cycles in order to facilitate the access due to cost. What do you think about continue combining azole plus Venetoclax plus ASA until progression? I consider that the indication of the antifungal agent is during the neutropenia period, especially if it's severe and prolonged. So I consider that the indication is to use it if it applies. I understand the problem of course you're adding another drug with potential side effects, and on the other hand, the patients that use azoles are encouraging in terms of complete remissions, but there's no data in the other type on the long term. Dr. Gomez, I agree. I think this is an area to be investigated. What we have published is with posaconazole in terms of equivalence in pharmacokinetic, and we are frequently using fluconazole because of cost. Voriconazole because of cost sometimes is not affordable for people who are in the public medicine in Mexico. So we need to use these old azoles who have no studies of pharmacokinetics and pharmacodynamics in combination with venetoclax. This is an opportunity for study in low resource countries. It should be explored. There's no evidence to recommend it, but this is something that we do. We all use during the induction. We start after the ramp up. So ramp up is the traditional one. And in patients who we only use it in patients with prolonged neutropenias. If they have short neutropenia, patients with R-CHOP have a 2 or 3 day neutropenia. It doesn't justify the use of azoles on the long basis. Okay, we go to another question. I don't know if we're going to be able to answer all of them. What is the experience of Bennett ASA as a bridge for transplantation? How many cycles? This is an excellent question. Personally, we've only had one patient that was a bridge for transplantation. We tried with ASA Veneto to obtain a complete remission with minimal residual disease, and that's why we prolonged almost 5 cycles. It was also an administrative issue. The patient lives in Ushuaia, but we haven't established a standard of care of how many cycles we need to administer as a bridge for transplantation. Today we have 2 patients who started as a venetoclax. One achieved complete remission, but in the context of the pandemic, we are prolonging that bridge. So these are perhaps are going to be a few months to sustain that response, and eventually we'll go for transplantation. I don't know if you have any similar experience. I haven't seen patients like that, but I understand conceptually speaking, the patient that goes to transplant as soon as he achieves complete remission, and I wouldn't delay that indication of transplantation after a few cycles of this combination. I agree with Nicolas. My experience is in 2 cycles, you achieve whatever you're going to achieve. And I have experience of 14 days of Venetoclax. And with that, I have achieved complete response in patients who were refractory to chemotherapy. So we don't have to wait too long. Many times you have to wait the administration, the insurance, things like that, the HLA. But in general, 1 or 2 cycles, if we achieve a complete response with negative residual disease, that's perfect. Perhaps the last question, in myelodysplastic syndrome with loss of methylating response, is you should add the Natoclax? I understand that this is not the initial decision. The studies were not designed like that. We always indicate the importance of the concomitant start of drugs. So I understand that the most standard indication in that situation will be the combination with low dose. We agree, although sometimes in the practice we don't always do it like this. But in those cases, we know that the response are going to be much smaller. Okay, our time is up. I would like to thank Andrés and Nicolas. I hope that this is an important exchange of ideas, and perhaps we can answer the rest of the questions via email. Thank you very much.